Okay, I'd briefly like to address some tips and tricks for how to study abdomen x-rays that may be helpful to us as x-ray techs. So here's some of my objectives. I'd like to illustrate the appropriate order for reviewing abdomen images. I'm going to give us one model of looking at them. It may not be the only model, but it's a helpful one. It's very simple. We'll discuss the basics of studying those images for abnormalities, examine some methods for scanning those images, and then we'll experiment with some of those methods ourselves. So, very first thing we want to do is review for details. We'll always begin with patient ID, date and time. So the physicians, just the same as us as technologists, are going to begin with those basic details. We want to get a good patient history, ask the patient why we're doing this examination, make sure that we're doing the right exam for them, and then ask them about any comparison studies, make sure that we have those comparison studies ready for the physician to review prior to sending the images to PACS. And I just want to show you an example of why this type of thing is important, especially marking our images, not just for left to right, but whether or not it was done in an upright or supine method. So on this image here on the right, we have an image that was done AP upright. And you can see, because it was done in that upright view, we're able to evaluate gas and fluid patterns a little bit more readily. And what we see here is a Burkitt lymphoma visible in those that abnormal gaseous distension pattern in the loop of the bowel in that specific area on the patient's upper left-hand side. So in terms of reviewing these images for quality, we want to assess the type and quality to include, again, whether it's supine or upright. We need to be noting that on our images. Diaphragm to pubic symphysis needs to be visible, no patient rotation. And we want to be asking ourselves, does the bowel obscure posterior structures? A lot of times if there's a whole lot of feces or something else in the bowel, it can make other organs difficult to evaluate. And so one good question is, are the psoas muscles visible? That's a good technologist question to ask, because it allows us to determine whether or not there's an appropriate amount of image contrast visible. And then if there's perforation suspect, we want to keep the patient upright for at least 15 minutes prior to the exam. And then we also want to ask whether or not we should be doing a chest x-ray, because they want to look at if there's air trapped beneath the diaphragm within the peritoneum. So an easy mnemonic to remember how to look at abdomen x-rays is just BBC, which stands for bowels and other organs, bones, and then calcifications and artifacts. So bowels, bones, calcifications, that's the order that we'll go through during this presentation. So first, go ahead and try this one out for yourself. Let's look at this picture and apply the BBC method. So first, we'll look at the bowels, and it does, right off the bat, there's something going on with the bowels. I can't see clearly through all of the intestines. Again, psoas muscles not readily apparent, but is it feces? Is it something else that's going on? Bones, clearly this, as I'm looking at the bones of this, is a very young patient, neonate, which is why we're doing chest, abdomen, pelvis on them, pretty common. And that's also revealed in the artifacts. There's some kind of NG tube or there's leads, there's all sorts of artifacts on the image. So what we've got here is free air within the bowel, secondary to a perforation. So again, that's just kind of feeds into why it's important to make sure we're getting appropriate history on the patients, and then anytime we suspect bowel perforation, being able to visualize the chest and the diaphragm. In this case, the patient is supine, of course, because they're premature, so there's no way to do an upright image on this. So the gas, if you will, is trapped there just in the dome of the abdomen, as opposed to being trapped beneath the diaphragm. So bowel and other organs, let's continue on with this and go a little bit deeper into the BBC mnemonic that we're using. Small bowel should be more central, and then the large bowel will frame it kind of on all sides. Small bowel mucosal folds will be seen kind of across the full width of the abdomen. For the large bowel, it's kind of more variable, and that can be a little frustrating in terms of looking at the large bowel. And the 3-6-9 rule is helpful because it tells us what the normal diameter should be for things, so the physicians can measure this on PACS in the workstation and determine whether or not the measurements are within normal ranges. But normal diameter for small bowel should be 3 centimeters, 6 centimeters for the colon, and 9 centimeters for the cecum. So anytime we're evaluating for small bowel obstruction, one of the very first things we're going to look at is dilation of the bowel itself. So we'll make those measurements. If it's 3 centimeters or greater, we're going to be highly suspicious of a small bowel obstruction. And then another giveaways is this coiled spring appearance, which is visible here on this image on the right. In addition to that, the valvulae convenientes are more visible, and those are those little haustral folds, if you will, kind of all throughout the small bowel. We can see them as small lines on this image here. And then this is most commonly caused by some kind of post-op adhesion or possibly a hernia. So we'll want to scan lower and see if there's maybe an inguinal hernia or something like that going on. For large bowel obstructions, these are most commonly caused by a carcinoma or a diverticular stricture, or possibly by a volvulus, which is a twisting of the bowel. And in this case, we have a large bowel obstruction. We have our measurements on there that 7 centimeters is greater than 6 centimeters for, what is that, maybe the transverse colon. It's difficult to tell because it's folded back on itself. But also on this image, we see that haustral fold. So we know that this isn't that lead pipe appearance that's highly indicative of like ulcerative colitis or something like this. This is an actual obstruction of the large bowel. Other organs we want to look at, we'll very first check the lung basis for consolidation, so like pneumonia or something in the base of the lungs. We'll look at the liver in the right upper quadrant. Gallbladder we'll want to review for stones along the lower edge of the liver. Stomach in that left upper quadrant, just looking at gas patterns there, if there's any irregularities or stenosis in the stomach. And then kind of do a cursory view of the kidney, spleen, and the bladder for things like irregularities or strange shapes there. Bones are going to be the next. So we're doing our BBC mnemonic. So we had bowels and other organs. Bones are next. So we'll look at the ribs that are visible, lumbar spine, sacrum, pelvis, and the proximal heads of the femurs. In this image, what we have are lesions, bony lesions caused by metastases from primary prostate cancer. And then calcifications and other artifacts. So things like gallstones in the right upper quadrant, renal stones, staghorn calculi, pancreatic calcification, vascular calcifications, any contrast lingering in the bowel or within the urinary system, surgical clips from surgeries, and then other stuff, quote unquote. And so, of course, I had to include an image here of the actor Ryan Dunn, who famously performed this stunt for a film in which he placed a car within his rectum. Ironically, Ryan Dunn also died in a car accident. So don't go putting things in that don't need to be places where they shouldn't be. And here's my references. This is a really helpful website if you're interested in more kind of detailed stuff. And then, of course, anytime you do a cursory web search, you can find out a little bit more. And then there's also videos out there of Ryan Dunn. All right, bye.